WHO defines health as a complete physical, mental, and a social well-being, and not merely an absence of disease or infirmity. Now, mental health is as equally important as physical health. Now, we know a lot of number of mental disorders that affect certain organ systems. In this session, we are going to learn about few of the disorders that affect gastrointestinal system. So let's begin our learning with functional disorders of gastrointestinal system, namely gastroparesis, functional dyspepsia, and functional vomiting. So what do I mean by functional disorders? Here, there is no apparent organic disease underlying, or the etiology or the pathogenesis is explained only by a functional method. So let's begin our discussion with gastroparesis. In a layman's term, gastroparesis basically means a paralysis of stomach. Now, stomach has been made up of certain smooth muscle fibers. It has got 3 layers of muscle fibers, which we'll discuss in detail. So whenever there is an affection, whenever there is an abnormality in the contraction of these muscles that are present in the stomach, it will lead to a delayed emptying of the contents of the stomach. And that condition is called as gastroparesis. Delayed gastric emptying in the absence of mechanical obstruction. Now we know whenever there is a mechanical obstruction, the contents that are proximal to the obstructions are remnant. But what if there is no mechanical obstruction, yet the emptying, the contents of the stomach are not being emptied effectively? So that condition is called as gastroparesis. Now 30 to 50% of diabetics suffer from delayed gastric emptying. Not necessarily this delayed gastric emptying can be considered under gastroparesis. Delayed gastric emptying can be simply a delay in a normal process. Normally, a gastric emptying occurs between 60 to 120 minutes. Now, when the gastric emptying occurs less than 30 minutes, it is called as a dumping syndrome or early gastric emptying. So, whenever the gastric emptying is delayed more than 120 minutes, there you can term it as a delayed gastric emptying. So, what are the common causes of gastroparesis? The most commonest cause or the most commonest group of people where gastroparesis is commonly seen is diabetes mellitus. Now, diabetes mellitus not only it affects type 2 but equally it affects type 1. And about 25 to 30% of individuals with gastroparesis have a no apparent underlying etiology or no apparent underlying association with any diseases. Hence, they are grouped under idiopathic. The individuals can have a prior gastric surgery with or without vagotomy. Now, the muscles that are present in the stomach are being supplied by both inhibitory and stimulatory nerves. They are both supplied by parasympathetic nervous system through a vagal nerve and a sympathetic nervous system also. So whenever there is a surgery, whenever there is a manipulation in the nervous system, be it in a myenteric plexus or be it in a sympathetic plexus or be it in a parasympathetic nerve, whenever there is a disturbance, there can be gastroparesis. So what are those surgeries which will specifically lead to gastroparesis? Especially any surgeries where there is a manipulation in the lower end of the esophagus or in the upper end of the stomach, especially an esophagectomy or a fundoplication or a Rox-NY surgery or any gastric acid reducing surgeries may end up in gastroparesis as a complication. Other rare causes of gastroparesis can be pseudo-obstruction, an association with collagen vascular disease, especially scleroderma. There can be association with infections. Now, it has been thought that even individuals who have idiopathic gastroparesis have a preceding history of viral infections. Now, viral infections change. They cause a conformational change in the myenteric plexus or the nerves which are present in the inner surface of the gastric serosa, as a result of which there can be occurrence of gastroparesis. So infections, when we talk about, most importantly, those are the viral infections which have a capacity to end up in a gastroparesis. And other associations are with neuropsychiatric disorders or anorexia nervosa. So before we begin our discussion on gastroparesis, we need to learn the anatomy of the stomach. So as I told you, there are 3 muscle layers in the stomach. One is a circular muscle layer, one is an oblique muscle layer, and one is a longitudinal muscle layer. Now these muscle layers are bundled up and formed across the stomach. Stomach is supplied by sympathetic system from T7 to T8 neurons, and a parasympathetic supply by vagus nerve. The vagus nerve, which is the 10th cranial nerve, runs from the thorax and divides into an anterior vagal branch and a posterior vagal branch and supplies the rest of the stomach. Now, apart from inhibitory action of vagus and the stimulatory action of sympathetic nervous system, there are various hormones, there are various chemical mediators which also govern the contraction and also the relaxation of gastric muscles. Now, as I told you, stomach produces contractions of its own. Now, there has to be some form of pacemaker. Just like there is a pacemaker in a heart at the level of SA node, similarly, a pacemaker is present in the lesser curvature of a stomach, which is also known as interstitial cells of Kegel, which are responsible to produce specific gastric contractions. Now, all of the cells which are present, especially the smooth muscle cells that we divided into circular, oblique, and longitudinal muscles, have got a resting membrane potential. Now, every cell possesses this. So, this resting membrane potential can range anywhere from 50 millivolts to minus 90 millivolts. So, the resting membrane potential differs from place to place. If we divide the stomach into two halves, that is a proximal half and a distal half, the resting membrane potential differs. That is how we have divided stomach into two parts. The upper part or the proximal part, which is responsible to store the food, which is responsible for known to cause a accommodation part of the stomach. And distal part, which is known for its powerful contractions, which is responsible and gives a place for mechanical digestion or enzymatic digestion of the food particles and also propulsion of the food particles into duodenum. So that is how we divide the stomach into an upper part, that is a proximal part, and a distal part. So this image shows you clearly how a stomach is divided as a proximal gastric part, which is responsible for contraction. Now, apart from the sympathetic and the parasympathetic nerves, which are responsible to maintain a balance between a contraction and relaxation, there are several chemical mediators, as I told you. One of them is a motilin, which is responsible for powerful gastric contractions. And all these mediators are responsible for gastric relaxations, such as gastrin-releasing peptide, gastrin, cholecystokinin, secretin, vasoactive intestinal peptide, somatostatin, glucagon, etc. Now, all of these are specially secreted or caused by a feedback mechanism by a distension of duodenum either with the food. Either there is a mechanical distension of a duodenum with food, or either this is a detection of amino acids or fat content within the duodenal lumen, which causes stimulation of these chemical mediators which are responsible to cause relaxation. And this feeling will give the individual of a feeling of satiety, which will make the individual feel that he is full. Now, as I told you, proximal part of the stomach, especially the fundus, the cardia of the stomach and the body of the stomach, is particularly responsible for storing food. So whenever an individual consumes food, this is the first part where the food goes, and depending upon the presence of the mechanoreceptors, there is a stimulation of vagal nerve through nucleus tractus solitaris, and after that there is a feedback mechanism as a result of which there is a relaxation, and that is when the individual feels satiety. After that, the food moves down to the lower end of the stomach. Now, the distal part of the stomach, which is primarily responsible for enzymatic digestion as well as mechanical digestion, takes its part, and after that it is propulsed into the duodenum with its powerful contractions, especially from the antrum and the pylorus. So, antrum and the pylorus primarily cause powerful contractions of the distal part of the stomach and cause propulsion of the food contents into the duodenum. So any defect in all of this process, either a sympathetic defect or a parasympathetic defect, or either a defect in the sensitivity of a mechanoreceptors, or any defect in the chemical mediators, or any excess in the chemical mediators, can affect a delayed gastric emptying and also can cause a early gastric emptying or a dumping syndrome. So as I told you, most commonly Gastroparesis is seen in diabetic individuals, and it equally affects both type 1 as well as type 2. It is seen that about 10 to 20 years of diabetes, there is an occurrence of visceral autonomic neuropathy. Now, we all know complication of diabetes, a long-term diabetes, especially what we see in clinics, that is either a diabetic nephropathy or a retinopathy or any cardiovascular diseases. Along with that, we also see peripheral neuropathy. Similarly, a long-term diabetes, there is occurrence of visceral autonomic neuropathy. And then this forms the basis for development of gastroparesis. So, pathogenesis, the exact etiology of how a high blood sugar or a high diabetic state for a longer time leads to gastroparesis is largely unknown. There are only hypotheses which can help us understand. Initially, it was thought that it was a vagal neuropathy, which is primarily responsible to cause gastroparesis. But even in individuals who have undergone vagotomy, their gastric emptying was quite good enough. So that proved us that just vagal or a vagus nerve is not just responsible for gastric emptying. There might be other factors also which might be disturbed in diabetes mellitus, which are responsible to form gastroparesis. There can be aberrant sympathetic function, even hyperglycemia. Hyperglycemic states are found to impair antral contractions and impair gastric smooth muscles. Now, these are only the hypotheses which can make us understand why a diabetic individual who has been having a high blood sugar for about 10 to 20 years might develop gastroparesis. Now, what are the signs and symptoms you would expect an individual with gastroparesis? As I told you, because there is a defect in the relaxation of this mechanoreceptors, because there is an impaired clearance of contents in the stomach, whenever an individual consumes almost 1/3 or half of the meal that he usually consumes, the individual feels early satiety or there is bloating. There can be nausea, anorexia, and vomiting because of a stasis of food, because of the irritation, because of the digestion and the acid contents of the stomach. There can be irritation, epigastric pain, or vomiting. Now, abdominal pain is seen in up to 98% of the individuals. The abdominal pain of gastroparesis is typically located in the epigastric region. It can be crampy, and sometimes it can be diffuse or dull aching also. Because of this feeling of early satiety, because of this chronic vomiting and a chronic abdominal pain, there is a reduction in a consumed amount of nutrients, as a result of which it can lead to weight loss also. When you closely examine the individual gastroparesis and when you put your stethoscope on the epigastric region and gently rock the patient, what you can hear is a succusion splash. It is the sound of the liquid or the contents of the stomach moving about when you try to auscultate in the epigastric region. So there is no any specific test to diagnose gastroparesis because it is a disease of functional origin. There is no any organic defect underlying. First and foremost, history is very important. Whether the individual is diabetic, whether there is any previous history of infections, whether there is any history of operations which have been done in the esophagus or the gastric region, is very important in considering a diagnosis of gastroparesis itself. Now, along with that, as I told you, there is no any specific investigation as such to diagnose gastroparesis, but you need to find out there is any associations with gastroparesis. Do a hemoglobin, which can be low because of a chronic malnutrition. Fasting glucose, especially to rule out any hyperglycemic states, which can lead to a defect in the antral contractions. STP albumin to look for secretory functions or synthetic functions of liver. Thyroid functions test, and ANA to rule out any connective tissue association. Vitamin B12 levels, and an oral barium contrast X-ray is specifically done to rule out any missed mechanical obstruction or a subacute obstruction can also be detected. And finally, endoscopy is done to not only diagnose a mechanical obstruction, but also to deal with the complications. Especially in individuals with gastroparesis, there can be an accumulation of undigestible material. A lot of undigestible material, especially fibers or plant-based materials that we consume, may not be digestible, and they are usually cleared in a normal individual. But in individual with gastroparesis, they can get accumulated, and they are usually seen as a large mass, and they are called as bezoars. Bezos can be large and huge mass. They can be easily removed via endoscopy. Specific investigation for gastroparesis include gastric emptying scintigraphy. That just means that along with a meal that you consider as a substrate, you combine it with a radio tracer and you ask the individual to consume the meal. And what you're going to see is the clearance of that meal, that clearance of a tracer, that is the time taken for the tracer meal to cross from the stomach to the duodenum. That will tell you a gastric emptying time. Ideally, the meal is an egg meal coated with technetium-99m amber light pellets. Now, the meal is selected in such a way that should be at least resistant to a pH of anywhere between 1 to 7. Now, this meal should be at least resistant for an hour of 3 to 6 hours of duration, because the tests usually are taken after 2 hours and after 4-hour interval after a meal. So at 2 hours, it is specifically done to detect a dumping syndrome, that is an early gastric emptying. And at 4 hours, it is specifically done to detect any gastroparesis, that is delayed gastric emptying. The other test that can be utilized is a gastroduodenal manometer. Here you insert a catheter per orally, you keep it for about 6 hours and you measure antro, duodenal and jejunal pressures. You measure if there is any abnormality, or you measure if there is any dyssynchrony between the contractions of the upper end of the stomach or the lower end of the stomach or the pylorus or the duodenum. It specifically differentiates between myopathy and neuropathy, whether there is a primary disorders of smooth muscle or whether there is a primary disorders of neurons. So myopathy can be either as a result of scleroderma or because of any amyloid. And neuropathy can arise as a result of any demyelination syndromes or because of any ANS or CNS disorders. Now, one of the investigations called as electrogastrography is recently in talk and is being researched. Here what they do is they place the normal electrodes of an electrocardiogram, they place it over the gastrium and they collect the baseline electric recordings. Usually these electric recordings are very weak when compared to the electric recordings of the heart. So a baseline is obtained. After that, a water load test is given to the individual. And again, an electrogastrography reading is taken after 30 minutes. So a response or any change in the electric activity that can be detected in this EGG is found out. But this modality is still being researched in many centers. So this is the image of gastric emptying scintigraphy. In the first image, A shows a normal individual. Here you can see substrate, that is a meal that is being mixed with technetium-99. The technetium-99 is a tracer that is brilliantly transluminant and it is seen in the gastrium at about 0 minutes. At about 30 minutes, it is slowly moving down and there is a adequate clearance of this at 120 minutes. So the contents of the stomach have been moved into the duodenum at about 120 minutes. The second individual, this is a normal individual. The second individual you can see at 0 minutes, again we have got a tracer and a meal. And at about 30 minutes and 60 minutes, what you can see there, just in a time frame of 30 minutes, the tracer has moved from stomach to the duodenum already. And at about 60 minutes or about 120 minutes, it has already well moved into the jejunum, in the second part of the intestine, small intestine. So this is an individual with early gastric emptying or gastric dumping syndrome. And the third individual, which is an image, shows you at 0 minutes a tracer and a substrate. Now the tracer and the substrate is remaining same even at 30 minutes, at 60 minutes and at 120 minutes. So that shows that the tracer has hardly moved over a period of 2 hours. That means that there are no gastric contractions. There is no any movement of this substrate within the stomach. This is a gastric scintigraphy imaging of an individual with gastroparesis. So typically the investigation of choice in an individual with gastroparesis is scintigraphy imaging. So the first image is a normal image, the second image is an early gastric emptying image, and the third one is a gastroparesis. So how do you manage this individual's gastroparesis? First and foremost, a modification in the diet. First and foremost, you should reduce the amount of solid food, because more the food is solid, longer the time it takes to clear from the stomach. So a liquid food which is less in fat and fiber, and several small meals. Especially an individual who's consuming 2 or 3 meals, you have to divide it into at least 5 to 6 meals. A reduction in fiber, because again fiber are going to form an increase of incidence of bezoars. Talking about medical therapy, prokinetics play an important role in individuals with gastroparesis. Prokinetics, especially metoclopramide, is FDA approved for gastroparesis, especially diabetic gastroparesis. Metoclopramide is a dopamine D2 receptor antagonist as well as a serotonin 5-HT3 receptor antagonist. Not only it has an antiemetic action, but also a prokinetic action, that it increases the gastric contractility as well as the pylorus relaxation. The dose that metoclopramide used is usually 4 to 20 milligram QDS, that is 4 doses in a day. It can be used even in intravenous form. The peak action when given intravenously, it is 3 minutes, and when given orally, it is about at 60 minutes. Other agents can be used, that is cisapride, erythromycin, or domperidone. If the individual is not responding to medical therapy, endoscopic decompression can be done. That means decompression of contents of the stomach to relieve a overload of the stomach, to relieve the stress of compression on the stomach. If the individual is not responding to even deeper compressive gastrotomy, a jejunostomy can also be planned. And lately, the therapies that are under research are botulinum toxin. Now, one hypothesis says that sometimes gastroparesis primarily results as a result of failure of relaxation of pylorus muscle. Now, the upper part of the stomach or the distal part of the stomach is able to contract. Atrial contractions are normal, but it is the pylorus that fails to relax and helps in stasis of the food contents. So injecting botulinum toxin directly into the pylorus causes relaxation of the muscle. And this therapy has been researched. Other novel therapies are gastric pacing. Here, either by open surgery or laparoscopically, you place electrodes on the gastric serosa and you give continuous stimulations to this gastric serosa and you pace the stomach. You induce muscular contractions within the stomach. Now, there was one study which shows 80% of individuals benefited with gastric pacing. Although that study consisted only of 33 members, and still this therapy is under being researched. Sildenafil, which is a phosphodiesterase 5 inhibitor, specifically has been tried in individuals with gastroparesis because it is known to cause a relaxation in the pylorus muscles again. Other drugs are loxyglumide, which is a CCK-A, cholecystokinin A antagonist, and clonidine, which is a alpha-2 receptor antagonist. Again, both of them are known to cause an increase in the antral contractions and are being studied. So as I told you, finding a bezoar is a major complication in gastroparesis. That is a collection of non-digestible fiber or plant-based materials within the stomach. So these are the endoscopic images of various types of bezoars. So by doing an endoscopy, not only can you diagnose, you can also take this off bezoars. You can break the bezoars if it is very large to be taken in a single piece, and you can remove all these bezoars. Now moving ahead to the another functional disorder of gastrointestinal tract, which is a overlap syndrome. Now, functional dyspepsia, which generally means an indigestion in layman's term, is basically occurring or in and around, or the pathology is in close association with gastroparesis again. Now, gastroparesis primarily is a delayed gastric emptying, but functional dyspepsia is primarily a uncomfortable feeling or epigastric pain or mainly of a dyspeptic symptoms. When you study about the pathology of either a gastroparesis or dyspepsia, many of the factors overlap. So what is the definition of functional dyspepsia? Postprandial fullness, early satiety, or epigastric pain or burning with symptom onset at least 6 months before the diagnosis in the absence of any organic cause. It is specifically seen with a female preponderance. There is usually an history of abuse And functional dyspepsia is seen to be morely associated in individuals who have anxiety or depressions. Another risk factor which is established is either a smoker and a history of use of NSAIDs. Now, Rome 3 has classified functional dyspepsia into two forms. Either a postprandial distress syndrome, which primarily has a postprandial discomfort. That is, an individual when consumes a food, he complains of diffuse abdominal pain and usually leads to a loss of appetite and weight loss. Or a second form where there is an epigastric pain syndrome. Here the individual will primarily have epigastric pain or burning or nausea or vomiting, which may or may not be related to meal. The first one is related to meal, the second one may or may not be related to meal. So what is the pathophysiology of individuals with functional dyspepsia? The first reason that is thought to be is an infection with H. pylori. The exact mechanism by how an H. pylori will lead to functional dyspepsia is not known. But it has been studied that 30 to 50% of individuals who had functional dyspepsia also had H. pylori in the biopsies. One theory is that individuals with functional dyspepsia have visceral hypersensitivity. It means that an individual with functional dyspepsia perceives a gastric expansion in a different way to an individual compared to an individual with a normal gastric function. So, when the gastric or the gastric serosa is dilated with its contents, there is a visceral hyperactivity. That individual with a minor gastric dilatation also feels more discomfort, more of pain. Or there can be an association with autonomic nervous system or a central nervous system disorder. There can be an impaired accommodation because of a failure of relaxation of the proximal part of the stomach. As I told you, the fundus, body and the cardia of the stomach, that is the proximal part of the stomach, is primarily responsible for accommodation. Any failure of the accommodation, whenever there is a loss of tone, whenever there is an increased contraction because of these chemical mediators, it can lead to dyspepsia or a delayed emptying. All the causes or all the hypotheses which can lead to gastroparesis can also lead to functional dyspepsia. How do you manage an individual with functional dyspepsia? If you find H. pylori in the biopsy or in any serological test, that is non-invasive test, go for H. pylori eradication either by a triple regime or a quadruple regime. Acid suppressing agents, especially with proton pump inhibitors, and use of prokinetics, because as I told you, there is an overlap, there is an indigestion, there is a gastric paresis, there is an increased accommodation failure. So metoclopramide, cisapride, erythromycin, domperidone have been tried in individuals with functional dyspepsia. Now, drugs that improve accommodation, that is, drugs which increase the capacity of the proximal part of the stomach to retain the gastric contents, can be used. Either a phosphodiesterase 5 inhibitor, that is sildenafil, buspirone or sumatriptan has been tried. And a drug which is called as STW5 or aberogast, which is a mixture of 9 herbs, has been particularly helpful in individuals to treat with functional dyspepsia. And lastly and foremost, very important, there is a behavioral therapy. As I told you, functional dyspepsia is typically seen in individuals with close association with anxiety or depression. In those individuals, behavioral therapy plays a central role, and also use of low-dose antidepressants, either a tricyclic or SSRIs. Now moving ahead to the next functional cause of gastrointestinal tract, that is functional cause of vomiting. So the definition for functional cause of vomiting itself will clear that there is no any underlying abnormality or there is no any underlying organic cause of vomiting. It says that at least 12 weeks, which need not be consecutive, in the last 12 months, all the following 4 have to be present for a diagnosis of functional vomiting. Frequent episodes of vomiting occurring on at least 3 separate days in 1 week. Absence of criteria for eating disorders, be it an anorexia or a bulimia or rumination or major psychiatric diseases according to DSM-5, according to the Statistical Mental Registry 4. Absence of self-induced and medication-induced vomiting, and absence of abnormalities in the gut or central nervous system and metabolic diseases to explain the cause of recurrent vomiting. So an individual has to satisfy all of the following 4 points and has to have these following 4 points for a duration of 12 weeks. They need not be consecutive, but this should occur for 12 weeks in the last 12 months. In individual whom you are suspecting functional vomiting, kindly exclude all the other organic causes of vomiting and functional dyspepsia as well, because it has been found that in individuals who are having gastroesophageal reflux disease primarily may present with recurrent vomiting, which might be confused as a functional vomiting also. So to rule out such individuals who are presenting atypically, a 24-hour esophageal pH testing can be done, where you can measure a basal acid output and a mean acid output, or a pH testing specifically less than 3 will diagnose a hyperacidic state. Treatment of individuals with functional vomiting primarily involves behavioral and psychotherapy. As this individual are having chronic vomiting, they'll be suffering from malnutrition. So adding nutrition to the diet is very important. And then symptomatic management with either using a prokinetic or antiemetic is beneficial. So to summarize, functional disorders of gastrointestinal system primarily include gastroparesis, functional dyspepsia, functional vomiting or functional constipation, and irritable bowel syndrome. We will be discussing irritable bowel syndrome in a session dedicated for that. Gastroparesis results as a delay in gastric emptying arising out of multiple etiologies, with diabetes being the commonest cause. The second commonest cause is idiopathic or infections, and rarely an association with connective tissue diseases. There's a complex interplay between sympathetic and vagal nerves may help understand the mechanism, although the exact mechanism of gastroparesis remains unknown. Mechanism leading to gastroparesis can lead to symptoms of non-ulcer dyspepsia and functional vomiting. That is why a close interplay or an overlap exists between the gastric functional disorders. Rome 3 has classified functional dyspepsia into postprandial distress syndrome and epigastric pain syndrome. Clinical features include early satiety, bloating, nausea, anorexia, vomiting, abdominal pain, and weight loss. Clinical features of especially individuals with dyspepsia or either gastroparesis are similar. And there is no any specific investigations to diagnose either a gastroparesis or a functional vomiting or a functional dyspepsia. There is only an established criteria which fits both for functional dyspepsia and functional vomiting. Although gastric scintigraphy can be used specifically to diagnose a gastric dumping syndrome or a gastroparesis. Treatment includes counseling, using of antidepressants, and primarily using prokinetics and antiemetics for all of the conditions. So this brings us to the end of our discussion on functional disorders of gastrointestinal tract, namely gastroparesis, functional dyspepsia, and functional vomiting.